When it comes to drug use in Idaho, there's a lot we know, and that information is sobering.
So in 2017, one resident died from a drug overdose every 36 hours. So if we look across the state of Idaho, Ada County had 184 deaths, Bonneville County 75, Canyon 59, Kootenai County 64, Payette County 21, Twin Falls County 47. So, it doesn't just affect large populated counties, it affects rural Idaho in a very, very real way.
Idaho's Office on Drug Policy works with community partners across the state to educate people about the dangers of substance abuse. And it's a high-stakes task, says Administrator Melinda Smizer. If a program is successful, it can save lives.
The challenge is we need a lot more of those programs that we can look through across the state that we can measure with data. I think those things are important. As I talked to the governor when I began this job, we have to look at how we can measure success.
Measuring success requires data, and that data needs to be dependable and complete. But some officials are concerned that when it comes to opioids, there are missing pieces to that puzzle. One example, the Prescription Drug Tracking Program, which interfaces with medical records, doctors' offices, and pharmacies to track prescriptions in an effort to prevent doctor shopping for opioids and other drugs. Idaho requires physicians and pharmacists to log in and enter information on prescriptions they give to patients. But there's a catch. Those medical professionals aren't required to check before doling out new prescriptions. In other words, they need to enter in their work, but not check anyone else's.
I was under the assumption that after we passed the other bills that it was now going to be pretty much mandatory that if you were dealing with any of these drugs, you had to be in this network and that information could be shared and stuff like that so that people couldn't shop pharmacies or shop doctors. But apparently it's not as robust as what I thought it was supposed to be. I am a limited government type of guy. I don't want to put any more regulations and stuff that's necessary. But I think anybody that deals in that legend drug area should be reporting what's going out.
Participation in the tracking program has gone up in the last couple years, with 7 million check-ins in fiscal year 2018. But there are still gaps. So why not mandate everyone check the system? Boise State University students looked into the issue.
One of their projects was to interview stakeholders to see how much willingness there was for a mandate like that for pharmacists, for doctors, and it was 78% against. So we're not even going to try and go down that pike. We're looking at other ways in which we can get results so we can save lives here.
Death certificates are another example of incomplete data. Each of Idaho's 44 counties has its own coroner, but there is no requirement that those coroners record overdose deaths in a uniform way. For example, Bonneville and Canyon counties record whether a death is because of an overdose, but don't always record the drug that caused the overdose. Of the 241 recorded drug overdose deaths in 2017, we don't know what drug caused 42 of those deaths.
If we could have a better way of tracking what exactly drugs they're using and they've overdosed from, then it would help us in the Office of Drug Policy pinpoint our focus more, working with our partners, how we want to come up with a strategic collaborative plan to make sure that we're focusing in the right areas around the state and on the right topics and working with the right groups, families, behavioral health, health and welfare.
Many coroners have very small budgets and they have to be very judicious about how they spend them. But I think they recognize that this is a priority and have been working hard to get more and more of our overdoses actually tested.
And sometimes there are cases in which agencies have information but don't have an easy way to share that data with other parts of government. Think of all the ways in which an opioid user might interact with the government, like law enforcement, the courts, an emergency room or crisis center, the child welfare program if their children are taken away, public health districts, county coroners. All those entities have information, but that data is often siloed.
I think one of the biggest problems we have and challenges we have in Idaho is that a lot of us have data, but sharing that data is really hard. You know, databases are set up to be private, you know, and to be used by the agency that's collecting it. So for example, in public health, we would really like to know more real time about, let's say, arrests. You know, if people are being arrested for fentanyl or heroin and there's a hot spot in a part of the state, the local police department may know that, others may know that, but we don't necessarily have easy access to that data. I think there's interest in sharing data, but it takes a long time and of course, money to really get that to set up and work properly. So it protects privacy, but also gives us the information we need to help combat the epidemic.
I guess at this point I'm not seeing what I consider as a good silo of what is all happening. It just seems to be in bits and pieces and in different areas. And that's a little bit frustrating to me at times.
And good data is critical to effectively combating opioid abuse.
We have 7 local public health districts in Idaho, and we have funded each of those public health districts to respond to the opioid crisis in their area. So they are working not only by hiring physician trainers who are working with providers in the community on good prescribing practices. They're also doing media campaigns, which we are targeting, especially to areas where we see more of a problem. But I think more could be done to target better. And I think if we had better data, like I mentioned with law enforcement, if we were able to share more easily, I think we could do more to really help respond.
But like so many other issues, sharing data in a streamlined way costs money.
I think our biggest obstacle right now really is resources. I think anything like this is a huge undertaking. You know, these large data systems, either getting them started or getting them to talk to each other while still preserving privacy where we need to. That's a huge ask. It takes people, it takes knowledge, it takes systems, either purchasing systems or building systems to do that type of work.
Despite the challenges, there are successes. The availability of naloxone, otherwise known as Narcan, is one example.
We gave from November 2017 to April 2018, 2,184 kits. We were able to save 36 lives last year alone. We're now working with a program, a mini grant program that is funded by the Department of Health and Welfare Center for Drug Overdose and Suicide Prevention Bureau of Justice. And this grant is going to be giving 500 kits out across the state to a lot of our most vulnerable partners.
I mean, all of us have slogged through the first couple years now of just trying to get our arms around this, and now we're coming out with really, real beneficial work.
So I think all those factors together, you know, it's like I always think of it as like turning a big ship. You know, it takes a long time when something's been going along for a long time, but I think all those things together are helping to turn the ship.